Hi, guys. Thank you all for coming. My name is Jordan Tishler. I'm a physician, and I'm here to talk to you guys a little bit about pain management and consequentially reducing opiates. I'd like to take a moment to thank you all for coming. I think one of the things that I've gotten out of this conference in spades today has been the vast number of interested folks and the astounding amount of research and development that's being done, and I think it really warms my heart as a clinician. And I would also like to take a moment to thank Cortigen and Medicinal Genomics for putting on this kind of an event. Yeah. So to take a few seconds just to explain who I am and why I'm here and blathering at you. I am a Harvard physician. I trained in internal medicine at the Brigham Women's Hospital, which I think is that way from here, but I'm a little turned around. And then spent the last 15 years or so working as an emergency physician for the VA. And so as you can imagine, I became de facto a bit of an expert on drug and alcohol, at least the acute presentation of that, and really came to see an awful lot of damage done by subjects, both legal and illegal. And that got me to thinking about cannabis as a safer kind of medication to treat patients. So my talk today is going to be a little different in that I'm actually going to focus almost exclusively on clinical matters rather than on research, because that's what I know. So pain is a huge problem. I'm not sure why I'm staring at this thing, and there's a monitor here. But pain is the #1 presenting complaint nationally. And pain is the #1 complaint that patients say we don't address well. So this is a huge problem. And I think one of the things that stems from that we have to understand as clinicians and as researchers is the problems that we're seeing nationally and even globally with opiate use are really a demand-side problem, right? Right now we have all of these governmental missives that say we should prescribe less, and doctors, you'll be held more accountable, and you need to look at the PMP and all this stuff, and that's fine Band-Aids, but really the problem here is that we don't have a particularly good way to meet the demand in a safe and effective manner. So enter cannabis. We need to understand the scope of the problem. As I said, our current approaches don't work that well. When you look at drug overdoses, the current statistics are they kill more people than guns, cars, and falling. And interestingly, we have this opiate crisis that we're addressing with major public health initiatives, but some of these things I think might well also qualify. When we break it down, the problem here is that we only have 3 alternatives, right? There are 3 drug classes that we can use to address pain, unless, of course, you look at the Massachusetts DPH silly initiative where they listed things like lisinopril, which is a blood pressure medication. But really, when it comes down to it, we're talking about Tylenol, right, which is in a class by itself, and we all know what that is good for. It's good for some things, but it also is not good for other things, and it has some attendant risk. There are non-steroidal anti-inflammatory medications like ibuprofen, right, or naproxen, which work well for certain things and also come with certain risks of GI bleeding or renal failure and those sorts of things, and not appropriate for all circumstances. And then what's left? Opiates. That's it. That's all we got, right? So we're kind of stuck unless we start to talk about cannabis. And then the question is, all right, well, what do we know about opiates? Well, it turns out that opiates have been with us for so long that they haven't been wonderfully well studied, particularly when it comes to chronic pain. And so in the last 2-3 years, we finally, in the setting of this declared crisis, got around to looking at these things. It turns out that opiates aren't that great for chronic pain. And they come with all sorts of side effects, from the obvious addiction issues, but how about just constipation? Anybody watch on television and there's now a drug out that you can take so you don't get constipated while you take your opiates? It reminds me of a children's rhyme. But this is where we are, right? And opiates are dangerous, duh, okay. I don't know about you, but I've known that forever. I have had a long reputation of being pretty stingy with opiates and getting in a lot of trouble in the early 2000s with my superiors because, as you remember, we had these groups come in and talk about, pain's the fifth vital sign, and nobody can come into the ED without being interviewed about their level of pain and exit interviewed about whether they were adequately, the pain was adequately addressed and stuff, and that put a lot of pressure on us to write more scripts. And not surprisingly, we did. Okay. What we know now is that when you look at the number needed to harm, it's only 33. 33 patients. 1 in 33 patients walking into your ED and you write a prescription, they're going to have trouble. They're going to either become addicted or worse yet, die. So not such a great idea. Now let me tell you about a success story. This is Teresa. Well, actually, it isn't Teresa. It's not her name. It's not her photo. But, oops. We'll talk about, go backwards, please. Excellent. Wonderful slide. But anyway, let's talk about Teresa. There she is. Teresa, whom I met in my clinic about 2 years ago, maybe 2.5, it really wants to show you the endocannabinoid system, but we'll leave it there and maybe it'll stay. 42 years at the time that I met her. She was a high-powered local attorney, and she had had the misfortune of having a car accident. And after the car accident, she developed 2 long-term consequences. One was she ended up with this weird seizure, pseudo-seizure thing that was going on, and nobody could quite put their finger on what that was all about. And the other thing, not surprisingly, she had a lot of musculoskeletal damage, and so she was in a lot of pain. So by the time I met her, she was at her wit's end. She had taken time from her high-powered job at great cost to her financially as well as emotionally, and she was on a serious handful of oxycodone, Percocet every day, and tramadol, which is a drug I really dislike. And she was being followed by her primary care doctor, a neurologist, and a pain specialist, and none of them knew what to do next with her, nor did they know how to get her off the opiates because she was in so much pain, but on the other hand, she was really suffering from the side effects of the opiates as well. Then to make matters worse, this poor lady, she had 2 young teenage daughters. The elder was an honor student whose grades started to fall off. She ended up, the daughter ended up starting to use illegal substances. And the younger daughter developed an anxiety disorder, which then manifested itself in suicidality and ended up having to be admitted to a local pediatric psychiatry facility. So life was not good when I met this woman. And what we were able to do was to treat her pain. And we treated her pain with a mixture of cannabis through various preparations. And so I'm going to come back to this a bunch of times, but I like to think of these things in the rubric that's with the analogy to the way we use opiates. And it's an uncomfortable analogy because we're trying to avoid opiates, but the way we're taught to think about these things is that we use a long-acting form of opiate to get baseline coverage. And then we use a short-acting form of opiate to deal with breakthrough pain, if there is any, on a daily basis. And so when you think about cannabis, and we've certainly heard lots and lots about different preparations and ways to use, what we know is that anything that you take orally gets metabolized by the liver and has a much longer half-life. It's also a little bit erratic in its onset, so that presents some problems. And then inhaled has a rapid onset and a relatively short half-life, so that works well in that immediate sense. And over the next 6 months, we were able to titrate this to the point at which she was no longer in pain. She was no longer in pain. Her mood came back. She was able to address family matters and get her children the help that they needed. And ultimately, the interesting thing was, even though her other physicians were uncomfortable with the idea of titrating down her opiates for reasons that I couldn't understand even after having multiple conversations with them, the patient just did it herself. She's like, look, I feel okay. I'm using the cannabis. So she slowly weaned off the tramadol and then next came off the Percocet. And at 12 months, she was opiate-free and her family was back on track. And I've been following her since, and she's had some ups and downs, but the principle is there, and the success rate, I think, is pretty good. So that's it in sort of the nutshell, the success story. And I'm going to now move on to this slide about the endocannabinoid system and really basically whiz past it because you guys have heard so much about the endocannabinoid system in the last 2 days that there's really not much for me to say. So we know that it's a complex signaling pathway, that it has both receptor and non-receptor mediated ways of functioning. And interestingly enough, this, what I haven't heard a lot of discussion so far is the ways in which the endocannabinoid system interacts with our inflammatory system around the prostaglandins and cytokines that are also involved in pain perception. Did you mention that yesterday? Okay. So there are interesting bits about the way the ECS works, that it works both peripherally and centrally. There's all kinds of really interesting data coming out now about its peripheral function. This slide basically shows us that it's a negative feedback loop, so that when these neurotransmitters stimulate the postsynaptic cell, then we get secretion of the endocannabinoids, typically anandamide, which complex then with CB1 and shut down the calcium influx channels, thus shutting off this release of neurotransmitter. But I think that's fairly well understood at this point. But the interesting bit about this is that we also get into paracrine, meaning secretion of endocannabinoids from non-neuronal tissue that are involved in supporting the neural tissue. And then we also get, come on slide, paracrine, whoa, come back. I'm really having trouble with the slides today, apparently. So paracrine function that affects inflammatory cells that are also involved, particularly in tissue damage, like histiocytes and macrophages. So there is a ton of processing going on at all levels throughout this system. Here in the central nervous system, we know that pain systems work both on an ascending, meaning it's going up to your brain, right? But there's interestingly a shutoff system where the pain systems trigger down again to turn off some of this and to prevent a runaway cycle. And we know that there's more processing going on there than we previously thought, and that there are these neurons in the spinal column, essentially here where the opioid receptor works, and that the CB1 receptor is tightly complex to that mu receptor there, and again is involved in signals that then dampen this feedback loop. Is this even worth mentioning? Nope. Okay. Back to the practical stuff. There are many, many ways that we can use cannabis, as we've heard so much about. In the clinical encounters, I typically start by talking about smoking, not because I recommend it, I really don't, for obvious pulmonary health issues, but people understand where I'm starting. All right, a little mood music. So typically, I will recommend that we move on to vaporizing. Vaporizing avoids products of combustion, but it provides an easy, repeatable dosing framework based on what I call puffs, or you might all call hits, although I think that slang is a little tainted. It has the following benefits. It's rapid onset, right? You get effects from it within 5 to 10 minutes. And also, it doesn't last that long, which in many instances is actually a benefit. So we're talking about pain today, but in many instances where I'm treating something that's more like anxiety and depression, it's nice to have something that has kind of a medium duration. Then we get into things that you can take by mouth, right? And it turns out when you look at some of the bioavailability studies that edibles is one of the places where the stoners got it right. That when you take cannabis in an oil form or as a solid form or those sorts of things, it's really poorly absorbed. You get about 30% absorption, whereas if you take it in a brownie, you get about 60% or 100% better. It's still not great bioavailability. And that really impacts how we treat people and the doses that they can take. But we also have to remember that patients are not just whatever problem you're looking at. Patients are complex organisms, just like you and me, where we need to remember the whole person, right? We're doing this in part as holistic medicine. And so I have all these patients that come to me, and they're elderly, and they're obese, or they have type 2 diabetes. Last week I saw a young woman, 31 years old, had been a type 1 diabetic since she was 18 months. She was telling me that her blood A1C level, which is a measure of her glucose control, was 8.9, and that was the best that she's ever seen. And I just marveled at that, because that's not a very good number. So clearly, and she came to me for intractable facial pain. Clearly, I was not going to go tell her, take 2 brownies and call me in the morning, right? So we have to work out something else there. I'm going to skip a lot of these other things. I think you've heard a lot about them, except to mention this guy. I think that oil-based vaporizer pens probably ought to burn in hell, because they are filled with all kinds of nasty things like polyethylene glycol or propylene glycol, which are dangerous. And the last thing we want is to treat somebody's pain and then have them have a lung transplant because, we gave them popcorn lung. All right, what's next? Which one is right for you? This is a graphic pulled from the internet. Apologies to its creator. But just the question is framing the wrong discussion, right? The issue here is not which one is right for you. It's how do we use these things properly. It's not either or. It's complementary, right? Again, I've slipped into doctor speak here. I hope that if people understand. PO means by mouth. And so this is our long-acting. And then inhaled is a rapid onset. Checking my time here. And, this was where I wanted to mention my diabetic patient, but the point is, I see this time and again. I see this, fortunately, we've heard from a few speakers this week about the dispensaries misguiding people, and I see this a lot in my practice, and one of the areas where that comes up is that they don't know medicine, they don't know the patient's problems, so I may send a patient in to get, say, capsules of something, and then they say, well, yeah, sure, here, buy some capsules, but don't you want the chocolate bars too? They're so yummy. And then the patient goes home and their blood sugar spikes, et cetera, et cetera. So we need to remember the whole patient. We've also heard a lot about dosing, and I think dosing is really crucial. What we know is that you start to get benefit as you increase the dose, and that's not really a surprise. But what is more of a surprise is that you turn a corner at some certain dose, and at that point you don't really get any more benefit, but you certainly get more side effect and risk, right? So these side effects may be as minor as dry mouth, which is something I can attest to at the moment, not from cannabis, but from speaking. But you also get things, particularly in the elderly, like orthostatic hypotension, which can lead to falls and such like that, as well as obviously increasing tolerance over time. So there are reasons why we do not want to push too far past this. In my practice, what I have found is that a dose around 10 to 15 milligrams, sometimes up to 20, and I guess this is milligrams of THC component in a whole flower product, or whole flower, really seems to be the sweet spot for almost the entire population. What is interesting to me, and this has been mentioned by other speakers, is that there are really two populations that come in. There are the cannabis naive folks. I've never touched this stuff, or I used it in the 60s when I was 20, and now I'm 75. And then there's this other group, which is sort of the smaller group in my practice at this point, which are people who are coming to me already using and wanting to either become legit, or they really have realized that there's needs for best practices for them. And I find that group comes in using way more than I would recommend to them. And then it becomes a much more, I think, difficult discussion to try and get them to sort of ratchet it back. And when they do, if they are willing to play ball, I find they get much better benefit. And they come back to me and say, Doc, wow, I feel so much better, and I'm taking so much less, and I'm saving money. I'm like, yeah, exactly, I told you. So this is the goal, and what's not the goal is this: grandma doing bong rips, okay? Yep, I'm 2 seconds from done. So assuming that this actually, yep, oops, no, come back. All right, well, on here is how you reach me if you want to ask me questions. I'm more than happy to go over any of this stuff with you guys. And somewhere up there was supposed to be the list of references. Come on, all right, forward one, references. So if you want to photograph that, you can go that link and find all manner of stuff that supports what I actually just talked about. Thank you all for listening.